high atop the Aubrey Plaza in beautiful downtown Wilmington, Delaware.
We are the Podcast Pediatricians. I'm Rob Walter.
And I'm Matt Gotthold. Check us out on iTunes, Spotify, YouTube, and a whole bunch of other places, as well as podcastpediatricians.com. Yes, another brand new Podcast Pediatricians episode. We're trying to do them a little bit more frequently, right, Bobby?
Yes, we are. And Maddie, our first two episodes was way back in March 8th, 2017. So this is our 9th anniversary.
Yikes.
About 100...
What were you supposed to get me? Something? Is it wood?
It's still
or
paper. It's still paper.
Okay.
About 100,000 downloads ago. You know, and I don't know about you, but I find people compare us to the most popular podcasts out there, like Smartless, Call Me Mommy. Your favorite Call Me Mommy. Not because we make insane money like they do, but we're also kind of idiots, just like them, but just with an MD after our name.
This is true, and I'm not sure how many people compare us to that. and we
they do.
Yes, and we're so silly. I think we actually lose money on this. But anyway,
we've never made any money on this.
No, from the beginning, we've always discussed trying to have shorter episodes and being somewhat less scripted. And since Roberto writes all the scripts, today, due to a combination of neither one of us having much time and also just plain laziness, we're going to just riff using some cliff notes from Hot Topics and our kind of broader sense of things that are going on in pediatrics right now. The things that we're using from Hot Topics is that's Rob's baby, and this is from last July. A bunch of interesting things that Rob came across.
We'll probably go longer than usual.
Oh,
I know that we will, but I'm excited
to
try to wing it a little bit the next couple episodes. And before we get to the top papers, let's review some things that happened since our last episode in December. Now, we all know that Matt is part of the incel community, and now he's into Looksmaxxing. Right now, he has a hammer, and he's hitting himself in the face with a hammer. But he's not all in on Looksmaxxing. He's not taking high-dose testosterone, which can lead to permanent sterility. He's not doing the peptide injection. So we do not endorse Looksmaxxing whatsoever.
Yeah, I mean, this is just another testament to the fact that the human brain doesn't mature until 25, and sometimes it never does.
And the boys are later.
Yes.
Oh, my God.
Yikes! Yeah.
It's incredible. All right, what's new? I have to tell the story. New Year's Eve, I babysat my grandson Noah, and classic rookie mistake as a pediatrician. What do? You're babysitting. He's on my chest. I'm watching a bowl game because what else are you gonna do on New Year's Eve? I don't love that holiday that much.
Me either.
And my daughter and son-in-law were out, and all of a sudden I heard. And I thought, okay, I'm going to have to change his diaper. It's a really good drive. Let's wait a little while, and the drive was pretty long. And then when I finished and I picked him up, I was covered with poop. Like it's soaked into my pores. And he's laughing, and I'm like, I didn't have anything set up, had to change him. It was a disaster.
Yike.
Disaster.
It's like a poop smackdown.
Yes, and he was laughing at me. What about you, man?
So let me see. What's news? Well, I think we talked about the fact that my second daughter got married. That's been great. They're still out there in Indiana doing great things. Go Boilermakers. As you know, the Eagles
they lost in the NCAA
dust,
tournament
and we're not going to talk about the Eagles biting the dust.
But didn't you like seeing the Seahawks beat the Patriots?
Oh, heck yeah.
Yeah.
Anytime the Patriots go down.
Patriots.
Yeah, indeed. And then let me see here. I went back to Guatemala for the second time.
I know you don't usually like to talk about that. It's so great that you do that.
But it was an outstanding experience. And, a microcosm of that was the last day I saw patients, I saw 35 kids, and 8 of them had undiagnosed asthma. And the best I could do for them was give them the one inhaler each that I had, because I had 8 inhalers and a spacer made out of paper cups, and essentially say, like, Godspeed, and I'll be back next year.
Right.
So, it's a little heartbreaking, but also you feel like, okay, gosh, there's work to do here. So I really enjoyed that. And then my one office, we have 2 offices.
We all know about Noah and the flood story.
Yes.
Matt wanted to reproduce the epic flood story of the Old Testament.
For the second time, yeah.
Second time?
Yeah, we flooded out like 10, 15 years ago.
Geez.
So a pipe burst in this, unseasonably hyper cold weather that we had, and my nurses came in on Monday morning to find 2 inches throughout our entire office. So we've been working through that. We're almost back to full speed. We'll get there.
Wow.
Yep.
That's stressful. And I want to shout out. Let's talk about your favorite subject, musicals. And I went to the Wilmington Drama League. Wonderful place, local here. Probably Johnny Gallagher Jr. Aubrey Plaza probably was there. But my very own partner, Dr. Maddie Houff, starred in I Love You, You're Perfect Now, Change. And I wish she had been in the Full Monty last year. Not doing the Full Monty. I wish I had seen that, but shout out to you. She's so good.
You've got some partner issues.
I think the Pediatrician is just a side gig for her, a professional thing.
Cool.
And I do know that you're not a Broadway guy, Matt, but I have to mention, last month I saw one of the greatest live performances in a musical in my life, right up there with Sutton Foster and Anything Goes, and watching the original cast of Sweeney Todd in '79, and then also of Chicago and Cabaret, and of course Hamilton. But it was Jonathan Groff and Bobby Darin's Salute Just in Time. And I loved him in Spring Awakening, Hamilton, Merry We Roll Along. But this was a tour de force. I actually got goosebumps. And I know you'll never see it, Maddie, but I just had to say that, if you ever one day decide you like Broadway, you should go see that show.
So actually, I did see it.
No.
Yeah.
You're just kidding.
No. My wife wanted to see it, and I obliged. And I'll say it was really, really good. As far as Broadway goes.
I know, the circle around, you're right next to him. Oh.
Yes. It was a good time was had by all. It wasn't anything I expected. And Bobby Darin, was a more interesting character than just the name.
Do a deep dive into Connie Francis and Sandra Dee from Grease fame.
Yeah.
So,
they were both excellent.
All right, so now that you've told me that, I think we have to do it. Are you ready, Matt? It's Mack the Knife. I love that song. Are you ready?
We can try a verse.
I know. We're not going to stop here. Oh, the shark babe has such teeth, dear, and it shows them pearly white. Just a jackknife has old McKeith, babe, and he keeps them out of sight. You know the shark bites with his teeth, babe. Scarlet billows start to spread. That's blood. Fancy gloves, though, wear old McKeith, babe. So there's never a trace of red.
Okay, I think that'll do it.
All right, Maddie, hit us with a disclaimer.
We're sharing our own personal opinions on pediatric care. Always talk to your own pediatric caregiver about your child. Pediatric caregivers should always consult expert guidelines and consider their own community's standards of care.
Okay, so let's talk about some recent pediatric papers. But first, let's talk about the big win. The Eagles didn't do it, but the American Academy of Pediatrics had a big win. We're both proud fellows of the AP. They sued the Department of Health and Human Services maybe last week. They won a landmark decision reinstating over $12 million of AP grants for rural health, mental health, SIDS, among others. And it also ruled that the AP had legal standing to sue about changes in the vaccination schedule, for which the judge found the government actions overhauling the vaccination policies by RFK Jr. were arbitrary and capricious. And blocked them. Mm-hmm. It's great, but sadly, a lot of damage has been done. It's going to be really, really hard to undo it.
Yeah, meanwhile, measles keeps creeping up on us, coming up slowly from the south to our area. It shouldn't be anywhere. But with 1,362 cases so far in 2026.
It's much higher than that now.
Outlandish, yep. And that's on pace to shatter last year's 2,284 cases. And more parents are not only refusing the measles vaccine, and we're seeing the manifestations of that, but they're even refusing vitamin K injections for their newborns. And as we've said before on this podcast, that increases the risk of babies having a brain hemorrhage by 88 times. Compared to somebody who gets the vitamin K.
Don't get a brain bleed.
Brain bleed, not healthy. But we continue to fight the good fight and explain the science to the best of our ability to the families who are getting bombarded with all of this misinformation and misdirection.
It's awful. All right, let's get to some papers. I love this paper. Antibiotic cocktails based on occupationally acquired immunity of pediatricians neutralize and confer protection against RSV and human metapneumovirus by Zai et al. In Science Translational Medicine, February of 2026. It was out of China. They just said, who would have better immunity than pediatricians who see sick kids their whole career? So they took 10 seasoned pediatricians. I think we would be in that category.
For sure.
In other words,
meaning
word
old.
for old.
Mm-hmm.
Yes. And they extracted memory B cells, and the average circulating levels of RSV were 3 times greater than the controls. And the researchers reported that the levels were higher than commercial passive immunity products.
Wow, like Beyfortus, what we're recommending for the babies now.
Yes, nirsevimab, Beyfortus, and Influenza now. Mm-hmm. So I was thinking, could this be our side gig?
It may need to be our side gig.
Yes, since they're killing primary care,
yes.
and we'll talk about that, but it may need to be our side gig.
So we have like superpower blood.
Yes, which made me think of, because I watched a lot of television more than you. Do you remember The Immortal? Christopher George, the Immortal.
No.
It was about this guy who was like a driver for a billionaire.
Was that silent? Like a silent
never
movie?
got sick. No, he never. It's a TV show in the 70s. He never got sick. And so then somehow it was an accident and he had to donate his blood to his boss who had cancer, and the cancer was cured. So then the boss wanted to just like lock him up and take his blood for him and his friends. So the whole show is him trying to escape the oligarchs, the billionaires, kind of full scale to these days.
Yeah.
But then again, I was also thinking, if telemedicine and urgent care continue to take all the sick visits because they'll give antibiotics to everybody and steroids to everybody, will we lose our super immunity?
Oh,
right?
True. Yeah.
I know.
Yeah. And will our patients, unfortunately, and all the kids suffer the consequences of suboptimal care? But I think we'll talk about that.
Like being in a third world country for some of the little babies with adult-oriented urgent care. Yep.
So the second article that Rob brings to the table is Virtual Care Provision and Emergency Department Use Among Children and Youth. So adult studies have shown that virtual sick visits, so telemedicine, have the same or less likelihood of follow-up emergency room department visits than the in-person type of visits do.
Right. This is in adults. This is just from December of 25 in JAMA, so it's a recent article.
Yep. Now, this article is the first that we know of assessing virtual care and subsequent ER visits in pediatrics. So the population cohort for this was huge. 2.6 million kids who are under 17 years old in the Ontario, Canada area, and it was between September of 2020 and March of 2024. Greater than 97% did not go to the emergency room within 3 days, but when they did, virtual performance versus in-person performance of the visits that had been prior to that, 0 to 3 months, no difference, higher risk ages, low threshold advice for
I think
ER.
The young babies, like if you get a real fever, you're going to go to the ER.
Yeah,
so
for sure.
That made some sense. It wasn't a big difference there.
It's kind of like a no-brainer, right? In the 3-month to 2-year-olds, though, nearly 50% were more likely to land up in an ER within 3 days of a virtual visit versus an in-person visit. That's
in
huge.
Pediatrics, that's huge. That's huge.
That's humongous, all right? And then between the 2 and 17-year-old group, 19% more likely to end up in the ER within 3 days if the visit was virtual as opposed to in-person. So we've been railing against telemedicine in its context of being used inappropriately. We do think there's a time and a place for it.
But sometimes it's convenience over quality.
Right. In pediatrics, though, the physical exam is really the proof positive of what our presumptions are through our history, and it's really critical in the vast majority of cases when we're dealing with a sick child, especially a younger sick child.
Right. It said, like in pediatrics, parents are the proxies for the child's history, so you can't get that direct history. And then these clinical signs may be too subtle for video, like work of breathing, dehydration, fussiness.
Exactly. So virtual care provision and emergency department use among children and youth, that was the paper. And the author's conjectures as to why pediatric care differs from adult medicine care is a variety of different things. As Rob said, these clinical signs that we look for in kids, which are often very subtle, and they have to be a consequence of somebody's experience over years and years. I mean, we find this when we teach medical students all the time. Like, this is not an easy peasy thing that Joe Blow from Kokomo can do over a television. Right? Mm-hmm. Even seasoned pediatricians struggle with making diagnoses that are accurate when they're not able to directly examine a patient.
Right. And then the eardrum exam, the lung exam, the abdomen exam, and the parents' emotional needs being in the room. So my takeaway was amen.
Amen to that.
Mm-hmm. And we're better for children in person than on telemedicine. Okay, another paper, kind of complicated, but I just found it fascinating, okay? Just fascinating. It was on autism. And background on autism, we all know autism spectrum disorder is very complicated. The hallmarks of deficits of social interaction, language communication, restrictive and repetitive patterns of behavior, a wide array of phenotypes matched by a broad genetic heterogeneity of individuals. And despite hundreds of ASD-associated genes identified, there's no coherent mapping of the genetic variations to phenotypes. Half of these genetic changes are thought to be inherited, half are thought to be spontaneous mutation. We know the diagnostic criteria for autism has greatly broadened since we trained.
You bet.
And it's felt that really is the reason we've increased the incidence, rising from 1 in 150 children in 2002 to 1 in 31 in 2022. It's not Tylenol.
Right.
And with such a spectrum of genetics and phenotypes, there's not been any coherent subtypes of autism described. People just say mild, severe, but there's not like any kind of distinct subtypes that we usually use. And it's still thought to be a problem with fetal development, like you're born with autism. So this paper, Decomposition of Phenotypic Heterogeneity in Autism, reveals underlying genetic programs in Nature Genetics in July 2025 from Princeton. Yes, a university doing scientific, getting funded. That's a good thing. They analyzed a unique cohort of 5,392 children with autism, part of something called the SPARK cohort database, with lots of phenotypic and genotypic data. And I don't know what this means. Using a generative mixture modeling framework, identifying classes of autism subtypes, analyzing diverging genetic profiles. They did a 239-item questionnaire for each of these thousands of families, an SCQ social communications questionnaire, an RBSR repetitive behavior scale, a CBCL child behavioral checklist, and background history. And they used GFFM, general finite mixture model. So it was impressive to read about it, and some of the reviewers saying, oh my gosh, I've never seen anybody do it like this to get so much information. And what they thought was it was going to be messy. We have patients with autism spectrum. There's no like one thing. It's like, it seems like a spectrum. How are they going to put it in subtypes? And they were really surprised that they did end up falling into 4 groups with very distinctive genetic and behavioral signaling. Broadly affected, 10% had the steepest delays, steepest challenges, difficulties, communication, social, repetitive behaviors that touched every part of life. I think that's what we would have called profound.
Exactly. So these are the kids that kind of nobody ever argues are autistic.
Right. From the get-go.
Prior to the
these would show up on our M chats.
Exactly.
100%. Okay.
Yeah. So they're the classic.
Right. And that's 10%. Then the second group, which was 19%, was called mixed autism with developmental delay. And that was 19%. They all had early delay, but few signs of anxiety, depression, or disruptive behavior. So that might have been what we said would have been picked up kind of early because they had delay, but it wasn't as profound. And that's 19%. The next group is moderate challenges, and that's about a third. These children with autism spectrum disorder showed the hallmark traits of autism, social communication differences, repetitive habits, but were more subtle and no developmental delay. I think some of these kids we would call quirky.
Yeah,
right?
The quirky kid.
But they were, I was thinking like who would I put in that category? Would I put Elon Musk? I don't know.
Yeah.
Like some of those social things, but no significant other issues. And then the largest group, 37%, was called social and behavioral. Met all the early developmental milestones on time. But they grappled with early conditions later on, including ADHD, anxiety, depression, and OCD, with distinct genetic profiles. This group was often diagnosed well after age 6, as was the moderate to a lesser degree. Now, there are no genetic variants distinctly put to each profile, but this analysis showed that some delay in the symptoms from these genetic mutations that are present in the child's born actually activate later in life. That an issue of fetal development is only true for some children, the timing of the autism diagnosis is not simply missing mild cases early on, is that the genes were not activated until later.
Wow, that really...
To me, it's like, wow.
That's
so
really
a parent's like, oh, I can't believe you missed this.
Right.
Like, you didn't miss anything.
Right.
These are later on.
And as you know, I mean, I'm sure you struggle with this just like I do. You know, oftentimes you're looking kind of eyeball to eyeball with a set of really anxious parents, and you're telling them, like, I'm not sure. Right.
Because it's activating later. And so you could say, I read this like, okay, maybe this is a one-off. This group got it, but maybe it won't be replicated. But then, months later, October 2025, a second study in Nature from a group from Cambridge in the UK with a different, completely cohort came to the same conclusions. They found the same breakdown for general groups, genetically distinct forms of autism unfolding on different timelines. And later onset overlap with ADHD, the mood type findings. So it further supports the hypothesis that the umbrella term autism describes multiple phenomenon with differing causes and developmental trajectories and correlations with mental health conditions.
Boy, it's one of these things where, and this doesn't happen all that often in medicine, but the more we know about it, the more clearly super complicated this is, right? And I wonder, as I was reviewing these notes, whether we're going to start to use different nomenclature for this, right?
And I've read other places that there's, to get services, but there's been pushback from I'll just say the autism community that says like, well, then people on the mild edge are not going to get extra help. On the other hand, there's a lot of conditions out there, medical conditions, where everybody needs help. So you got to say who needs the most help. Right. So it's complicated. And I will say again, getting back to that, this really isn't a disease. It's just part of the human condition. And in my experience, I think we said before, late diagnosis, and maybe in that third group where they're doing well, but they're diagnosed late, can be very life-affirming. Sure. For a teenager or a college kid who says, why didn't I ever get the joke? And like, oh, this is the way I'm wired. Right.
And we've both had patients like that, more than a few probably. Yep.
And we enjoy taking care of them and their families.
Yeah, so being in a position to kind of help to sauce that out with people and admit our own kind of lack of in-depth knowledge at this point, which I think is pretty universal amongst pediatricians. I think we all struggle with it, right? Is humbling, but it also gives, we're in a position to be helpful.
Exactly. We'll be right back after the break. We're back. Okay. We finished with some pearls from infectious disease and pediatric gynecology from Hot Topics and Pediatrics Disney last July. Shameful plug. Next year, Hot Topics, July 16th to July 18th, back at the beautiful, newly renovated Grand Floridian Hotel. We have a fabulous array of speakers once again, focusing on the experienced pediatric caregiver in their offices. You going to go, Matt?
I do. I go way out of my way to stay away from Disney.
You do go to a lot of them,
but I'm not sure I can make it this
I
year.
know, but you go to a lot of them. It's very much appreciated.
Okay, starting with some infectious disease from talks from Dr. Neil Relosa, a great infectious disease specialist at Nemours. We added some tips. As always, any mistakes here are all ours and not his. So I think we all noticed in pediatrics that Mycoplasma pneumoniae had surged last year.
Fall?
Yeah. Oh, it was awful.
Yeah.
So this usually tends to be a relatively mild condition, but it can occasionally have significant manifestations. It's usually treated with a macrolide, azithromycin. Somebody has a clinical pneumonia. Sometimes the struggle for us as pediatricians is whether or not we treat with simply azithromycin or with amoxicillin. We know what's in your community. We can ask infectious disease if we need to know. Mycoplasma is usually considered to be walking pneumonia. Typically with this, there doesn't tend to be a high fever. It doesn't seem to be localized to a single lobe of the lung like most common other pneumonias are. And we try to go with a single antibiotic to spare the microbiome, which we're increasingly interested in doing. If you remember a few podcasts ago, we talked about the possible effects of antibiotics on children long term, right?
Right, on anything from food allergies to asthma
to ADHD to
intellectual
everything.
disability.
Yeah, sure. But sometimes if a child's pretty sick during a mycoplasma surge, we'll occasionally prescribe both of these things because it gives us coverage over several different types of bacteria.
And one thing I think we both do less in ER or urgent care, we don't get a chest x-ray on everybody who we think has pneumonia, unless there's complicating factors.
No.
But that's radiation exposure.
For sure.
And there's been papers in the last couple of years that even crackles on exam doesn't always line up with the chest x-ray results. But maybe the chest x-ray results are wrong because it's too early.
Exactly.
The other thing, I don't know about you, but sometimes when they come in with, crackles and breathing issues, I'm thinking, is there a bronchospastic component? I mean, there's so much bronchospasm out there. So I will, in my office, we have spacers masks. We don't have to do a whole neb. We can give them a few doses and see if they feel better, especially if they have that coughing history of, coughing till they throw up, or every time they laugh, they cough, and family history or personal history of wheezing before. So they can have both. They can have pneumonia and bronchospasm, but you don't want to miss the bronchospasms.
No, you're absolutely preaching to the choir here. We just had a big discussion amongst the providers in our practice about the utility of trying to use a bronchodilator when somebody comes in with this presentation, and how effective it can actually be, even to the extent where you don't need an antibiotic. Right. I mean, I do this all the time.
And I will say also, if you are going to think it's effective, then also don't send them home just with albuterol.
Right.
Give them an inhaled steroid. Even better when they're older, the smart therapy with the combination. But anyway, we're preaching to the choir.
Yeah, and I don't know, this is just a real quick sidebar, but both flu A and flu B this year both seemed to me to have bronchospastic characteristics. Yeah. I saw, even as recently as last week, I was seeing kids who weren't necessarily wheezing or having, kind of a complete disappearance of their breath sounds in an area, but just throughout their entire lungs seemed not to be able to move air as well. And they responded beautifully well to a bronchodilator.
Right. Yeah. But you're in the office, you can hear them. You can't do that in telemedicine.
And it was subtle, because I think somebody who's not a pediatrician, or at least even somebody who might not be a seasoned pediatrician, would have missed that because there's no sound that's unusual. It's just a lack of sound that's unusual.
Right. That's always the hardest thing, is when you don't see something that you should see. And I don't know about you, really bad flu season, influenza B lately, influenza A seemed to be sicker, had a couple of cases of really severe myositis, the classic calf pain. One had to get admitted overnight with, huge CPKs, and then also had one case of someone having influenza encephalitis. MRI lit up, change of mental status, intubated, everything, doing great. But, influenza is a serious disease. And I know it doesn't mean the flu shot can make it so you won't get it, but you're much less likely at the very least to get it, but to get hospitalized and to get complications. All right. What about strep, Maddie?
All right. What about strep, huh? Okay, so first line for group A strep is always penicillin or amoxicillin, and it can be used once a day. I still tend to, I think just because I'm old, divide the dose into twice a day. I also think it's easier on the stomach, but maybe that's just me. It's certainly approved for once a day.
I still do once a day, 50 per kilo, max like 900 or something like that. It's easier to kill than some other things. And then the amoxicillin to labeling. I'm not sure you're doing it yet.
Not yet, but it's certainly on my radar,
Okay, because you don't have to do the cephalosporins, which mess up your microbiome and give you more side effects. And Dr. Velosa mentioned if there's an issue of strep carriage, which is also another thing that could be difficult to prove, that you want to use clindamycin, 20 to 30 milligrams per kilo per day, divided 3 times a day for 10 days. And we all know clindamycin tastes disgusting. Awful. So his tip was put it in citrus or in dark chocolate.
You remember back when we did the strep episodes? I think it was the first or second year. I thought those were some of our, really comprehensively interesting.
Yes, so comprehensive. Yes, go back to listen to those. Also, he mentioned about tuberculosis, and we also covered this, that the IGRA versus the TST, the old PPD skin test. The AAP guidelines still say under age 2, you should do the skin test. But we know there's a great variability in placing them and reading them. IGRA is particularly good if you had a BCG, because you won't get false positives if you have a person who got a BCG overseas. And the skin test, PPD, can be good if you're looking for non-TB mycobacterium, if you have like a node in the neck and such. But there are multiple papers that the IGRA is even good under age 2. Yeah. We don't like to go against the AAP guidelines, but I just feel like I'd be much more comfortable with that if they're not too young to say, if they have it or not. I don't know about you.
Well, I think you and I trying to be, kind of practical/critical about AAP guidelines, we hardly ever differ. Right?
Right.
But I think that's also the premise that we started this podcast on.
We
disagreed with
in-rooming
in-room
babies
keeping your baby in your room for the first 6 months.
12 months.
That was the whole impetus to start this podcast
based
back
on
in 2017.
5 papers. It feels terrible. We did our research in Europe that everybody was smoking in the room, and they didn't take into account the parents' mental health. It comes up all the time in the office. We're talking about like, if you want to have your baby in the room until
knock yourself out, but like,
that's great.
Right?
Yeah.
All right. So a couple other pearls from Dr. Relosa. Never send tests for C. difficile if the stool is formed. And if you do send it, be careful about sending it for a child under 2 years old, because they may be actually colonized with C. diff and it's not acting as a pathogen. It's just part of their routine gut flora. Be judicious about multi-pathogen GI PCR panels. These look at 23 pathogens and they can have false positives, especially if it would not affect your management. You should bypass these more likely than not. And sometimes for mild diseases, or even for diseases that can be pretty significant, like Salmonella and E. coli, you wouldn't necessarily change what you're going to do in an immunocompetent child, at least, right?
Right. So then you see, and I don't know how it's expensive. So I don't order those very often.
Oh, I really try to encourage.
They can be really helpful with continued and a sick kid with diarrhea, but I don't get those 23 GI PCR panels very often.
Yeah, I mean, I think you and I teach the same way, which is, you want to use a test for information that's going to matter.
Right.
And sometimes the matter isn't necessarily for the patient. It can be for the family as well, right? But there has to be a reason to order a test that is useful.
Right.
Not
if
just out of curiosity.
neither result would change anything, why are you getting it? Right. So mono is something we see all the time. And I have to say, this season, kind of like the fall, winter mono season, I saw multiple kids who went to, again, an urgent care or something like that, and they got the mono test, the qualitative, the old mono spot, and it was positive with a diagnosis of mono, but they had no mono symptoms. They didn't have the bad sore throat. I mean, they had nothing to make me think it was mono. And so then and it was a big deal because they couldn't do sports. So then when I retested them an EBV virus test, it was negative. So it was not mono. I know mono test of qualitative is supposed to be very sensitive specific, but your pre-test probability, if it doesn't make sense that they have mono, then you're going to go down a road and really affect somebody. So
I think a lot of urgent cares, and I find even hospitals now will just, as soon as you hit the door, they institute a protocol.
Yeah.
And, a very good friend of ours, his mother-in-law was recently in the emergency room with a cough. And before any provider laid hands on her, she had blood work, a chest x-ray, and a chest CT.
Wow.
Like, okay, so you just spend about, $3,000, maybe more, on things before anyone even looked at her.
Right.
Crazy.
It's crazy. Again, getting back to mono, because it always comes up with sports and going back, and he gave some nice pearls, Dr. Velosa, that we always talk about you have to be checked in 1 month. But after 3 weeks, you can do some activities, gentle, almost like when we return people to a concussion. You could do some light workouts and stuff. You don't have to be doing nothing.
Right.
And then wait to do the heavy stuff until we see you and we can check if there's a big spleen from 4 to 6 weeks after the onset of the illness. There's very few reasons to get an ultrasound of the spleen. I'm sure professional athletes might do that, or the NCAA, because NCAA athletes are professional athletes now too, getting millions of dollars. There's no reason to repeat EBV testing, and there's not great data on spleen guards to use for mono, so it doesn't really make any sense.
Yeah. I don't know if we've talked about this before. I don't know if you ever had a high-level athlete who had mono and they were kind of like due to pitch tomorrow, right? And I can distinctly remember a case probably 15 years ago where I had a guy who was pitching in the finals, kind of the final series here in Delaware. He's a high school student, and I would have him come in every single day, so I could, because he was pitching most days, to check his spleen.
Right, and I don't know what the protocol is, but maybe an ultrasound. I would probably call radiology and say, is there any kind of protocol that we can do that?
Yeah.
But even more so, which we don't do anything, we can't rush it, is the concussion kids.
Oh, no.
It kept kids out of the state finals because of a concussion, and they're not happy.
Okay, so moving in a slightly different direction. So if there is a young child and a bat,
the bat
thing
is
found in the house overnight,
right?
Then the child should, by all means, get the full 4-dose rabies vaccine, even if there was no history of bites. So this comes up for both of us a handful of times a year, and it's really a challenge to explain to parents that, despite the fact that there's no obvious bite, that the risk for rabies is so catastrophic in terms of the outcome,
right,
that it is indeed worth their child having
100% fatality.
shots.
I think there's one kid at Children's Hospital Wisconsin didn't die, but pretty much you're going to die.
Exactly.
So you don't need any much more of a possibility than a bat was in the house, a little kid who won't tell you if they're bitten on their toe. Yes. So that comes up.
Although this happens in our practices, it doesn't happen enough for us to actually have the rabies shots in our practices. So this is usually facilitated through a local emergency room.
And I think our Nemours, they do a really good job.
Very good.
All right, Lyme disease. We're in Lyme country here, so that comes up. We've grown up with Lyme disease. He just touched base with some pearls about prophylaxis, just to remind us that doxycycline, 200 milligrams or 4.4 milligrams per kilo for children, if it's given under 72 hours, if the tick has likely been attached for more than 36 hours. And doxycycline can be given at any age. Remember that dark chocolate and citrus? When he mentioned this at Hot Topics, someone yelled out, I recommend taking it with a Taki, the spicy. Have you had Takis?
I've not.
I have not either.
But I hear they're
thing.
really good and bad for you and
really
delicious.
Yes, all right. Takis with doxycycline.
So was Dr. Relosa, since I wasn't there, was he recommending this as an option, or is he saying
prophylaxis?
If you go, if you go this route,
if you have someone who has had that tick embedded for more than 36 hours and you're in the right place and you really feel it's likely a deer tick, why wouldn't you want to prevent it?
Well, because I'm always oftentimes I'm a little bit dubious about how long it has been on there, right? And because the parents are like, I don't know, maybe been on there, an hour ago.
I know it's
right?
hard, but we're such a Lyme area here that I personally don't have a problem saying, okay, let's go ahead and give the one dose of doxycycline.
All right. So remember, when removing a tick, fine tweezer, nubbed up against the skin, and then pulling up and out, including the mouth and the head, is the way to do it. Now, if you leave the mouth and head in it, if you have a hard time getting it out, this is not
no big deal.
Horrific.
Right.
This you've removed the source at that point, and at that point, I think both Rob and I consider that mouth or that small amount piece that was left over to be a foreign body. So it's not a nidus of infection, for the kids.
Right.
We try not to twist or to jerk the tick, although I think in the past we've talked about the fact that one of my go-tos on rare occasion, I think I use it once a year, is a gauze, because the stickiness of the gauze will actually pull the tick out really kind of nicely and cleanly without having to fiddle around with a fine tweezer. But you want to leave the tick as intact as you can, especially the body. You don't need to get a Lyme test if the child has a classic erythema migrans rash.
Right.
So we as pediatricians certainly know what these look like. So Lyme testing itself is a two-tiered test, first with a enzyme immunoassay, and then with a Western blot, both IgM and IgG. But remember, if it's been more than 30 days of signs and symptoms, you really don't diagnose Lyme disease based on the IgM alone. At that point, the IgG should be present as well, and that needs to be positive.
That's a key thing, right?
Yep. So we've had many children, months after symptoms started, and they were vague enough that the parents weren't sure what was going on, who just have 2 or 3 of the IgM positive bands, but have no IgG, and that is not diagnostic for Lyme disease.
Right, and you have to explain that. Even somebody sent to the Lyme Center because we talked about being judicious.
Lyme
I'll give them the prophylaxis, but I'm not going to treat them for Lyme if it doesn't make sense that they have Lyme.
Right.
And one other thing he mentioned, which bears repeating, is that yes, amoxicillin can be an alternative to doxycycline, but it's not as good. It's not as good. So I know we're used to amoxicillin,
sure,
but we can use doxycycline at any age. Okay, you're not going to get teeth issues and such. You're just using it for a week or 10 days. Exactly. So really, there's not much of a reason to give amoxicillin over doxycycline. And speaking of doxycycline, be aware of Doxy PEP. Do you know Doxy PEP, which is post-exposure regimen to prevent chlamydia, syphilis, and even gonorrhea by 50 to 80%? Which is crazy because doxycycline is not effective to treat gonorrhea, but if you use it, you can prevent gonorrhea. Remember the 2-3-1, 2 Doxy pills or 200 milligrams taken within 3 days of condomless sex, although the sooner the better, taking it at 24 hours is better, and only use once a day. This is only approved for age 18 and up, which I don't understand why a 15-year-old couldn't do it, but that's the official approvement. And then remember PrEP, pre-exposure protection for HIV, the daily pills. We have to do some pre-testing, or now there's a Q2-month injection. So I do this sometime in office, but I do mention if I think there's high-risk reasons, they should look into this, whether it's me or somebody else. And also keep in mind, speaking of doxycycline, keep in
while
mind,
we're on a doxycycline
Rocky
roll.
Mountain spotted fever with a classic rash starting at the wrists and ankles and then trunk. It can turn petechial and can cause overwhelming multi-organ failure. If you see anything like this, start the doxycycline. Some people call it doxycycline deficiency syndrome. If you think it's one of those, you'll get the specialist involved, but don't hesitate to reach for the doxycycline.
All right, and while we're on the doxycycline roll, let's get on the tick roll here. So keep in mind that there can be co-infection or singular infection with other tick-borne diseases like babesiosis, ehrlichiosis, and anaplasmosis, oftentimes with even higher fevers and changes in complete blood count with lymphopenia and thrombocytopenia or anemia, and not just getting better after somebody's been treated with Lyme. So oftentimes the disease is concomitant, the Lyme disease is concomitant with another one of these tick-borne diseases. And yes, while we're on bugs, let's go with mosquito-borne diseases. These are also on the rise. Holy guacamole. All right, like dengue and chikungunya. Is that how you pronounce that, man?
Chikungunya.
Nicely done.
Thank you.
Yeah. The latter, the chikungunya, look how quickly you taught me. The latter does have a vaccine, but it's only for patients 18 and older.
And I had a case of dengue this season from a high school trip to South America, hospitalized there, did well, but I went researching it because, you get these stories, you go right to UpToDate. I'm like, okay, maybe open evidence and say, okay, what do I need to know about this? And it's just scary that if you get dengue, the problem is if you get it again, then it could be overwhelming. So like now you're thinking, okay, now if I go to a high-risk place, I really need to be careful not to get it again. The other lesson I think for this student might have been just protect yourself against mosquito bites on trips to high-risk areas. Even if Google says don't have to worry about it, okay? Just a lesson learned there, I think. And Dr. Veloso also mentioned, again, knowing about malaria and having a trusted travel clinic. We've said this before. I personally, if I'm going to prophylax, use Malarone daily and not Lariam because of the psychiatric side effects of Lariam, besides intense dreaming, can be kind of chilling and often persisting and scares the heck out of me, although it's tempting because it's only once a week. And these dreams were a plot point in State of Wonder, a great book by Ann Patchett. Can I pitch it for our book club? I guess I read it.
You can try.
I think it's probably too many feelings for some of the people in our book club.
Yes.
Yeah, some of the people in our book club do not like to get into will not be named, not Matt and I.
They don't want to mind their emotions.
Feelings.
Yes.
They don't like feelings. Science fiction
more
works.
Did I ever tell you about the boy-girl party I was at in 7th grade? And
No.
It lasted for 3 hours, and the only music we had was the song Feelings. and the girl who was hosting it just started playing that over and over. I swear I heard it 30 times to the point where I get nauseous now if it comes on the radio.
First of all, I want to go to that party. I want to be watching that. That's
nothing more than
there was
feelings.
there was an old Carol Burnett sketch when she would always talk about that song.
Oh my goodness. All right. So shifting gears again, congenital syphilis is not a medical emergency.
Not a medical emergency.
But it is increasing. Yes, penicillin is still the first line, but there are very specific algorithms to follow.
And they're complicated.
Yeah. So, and it's something that thankfully we usually have our specialists take care of.
Yes.
In the old days, if a mom had HIV, there was absolutely no breastfeeding that was recommended. But that's not necessarily the case anymore. If a mom has suppressed viral load, meaning that her HIV is well controlled, and if she is on ART therapy. But often the baby is treated until the breastfeeding is done. Having a C-section is now only when there's a high maternal HIV load.
Right. So for many of these women with HIV with a low load, they don't have to have a C-section. They can have a vaginal delivery, and they can breastfeed. Mm-hmm. A big change.
Huge change from when Rob and I first started. So moving on to yet another pathogen, Over 50% of children with CMV, that's cytomegalovirus, associated hearing loss, can have further deterioration of their hearing over time. And that's why it's key to diagnose it early and potentially treat these babies. So, Rob, you and I both know that CMV is an extremely common infection and that there's a window of opportunity to test a baby for this because oftentimes by the time they're, quote unquote, out in the world,
a couple weeks,
they're going to acquire it anyway. Now, that acquisition does not, routinely, as far as we know, cause any issues with their hearing. But it's the intrapartum time when we're most concerned about that. So in the newborn hospital, where most of our babies are born, they routinely send CMV on a baby if they fail the initial hearing screen that's done within the first couple days, even if it's only on one side. So we're taking this very seriously. And many will pass on a repeat test. But if you want to determine if they have CMV early in the first 2 weeks, that's the time to do it, because other than that, as we said, you can just acquire it naturally, and then it gets really confusing. Last year, the state of Minnesota became the first state to implement universal screening for CMV, and they do that similar to the way that we do the hereditary metabolic disease screens, and it's just a matter of putting a little blood spot onto paper, and then that is analyzed for CMV. And if it's positive, it can be confirmed with a urine PCR, and that all happens within the first 3 weeks or so of life. If the baby's positive for CMV, it's recommended that they get a workup to see the other potential manifestations of CMV, like a CBC, liver function tests, even neuroimaging, further audiology testing, and an ophthalmologic exam.
Right, and yay, Minnesota. For many reasons
yay,
lately.
Minnesota.
But yay, Minnesota for this.
Uh-huh.
I'm hoping that'll spread, that we can all diagnose CMV early. So we're going to finish with some pediatric gynecology pearls from our local Peds Gynecology superstar, Dr. Beth Schwartz. And again, just with Dr. Velosa, anything we say that's wrong is on us, not on her. First of all, the exam. Pediatric gynecology exam. You're supposed to just do gentle labial traction, the pad of your thumb and the knuckle of your index finger pulling out and down to gently see. And it's something that really has to be done correctly on both sides to get a really good look. And you can first look for any hymen anomalies, septate, microperforated, imperforate. It can prevent with not being able to get a tampon in or intercourse issues. An imperforate hymen can present with monthly abdominal pain, with the outlets being blocked so the blood can't go anywhere and you get cramping. And sometimes you can see bulging of blood. I saw that once in my career. But it is something that you should be, as a pediatric caregiver, facile about doing the exam correctly.
Yeah, so labial adhesions, which is essentially where the two sides of the vaginal labia essentially stick together, and this happens pretty commonly, and it peaks somewhere between 3 months of age and 3 years of age, and oftentimes the baby has no symptoms. In fact, I'll argue almost all the time the baby has no symptoms. The fact of the matter is that much of that can be fused together. All the baby really needs for their bodies to function properly is that the urethral area is open so that they don't incur UTIs or other uncomfortable manifestations of these labial adhesions.
Right, so they just need the very tippy top to be open.
Yeah, the very top, and the urethra is at the very top of the vaginal introitus, so that is where we need to make sure that remains open. One symptom in kids who are a little bit older is that they can have wet underwear, even though they're completely potty trained, and this is because some of the urine can get trapped behind the labial adhesion and then kind of excrete itself after the fact.
And that's why we would treat that.
Exactly. And so if one treats it, now this is Dr. Schwartz's recommendation. If treated, she suggests using betamethasone propionate cream until it opens, and then Vaseline twice a day for about 6 months just to make sure it doesn't re-adhere. And she does not use topical estrogen, and that's the way Rob and I were trained.
But I don't use it anymore
decades
either.
ago. I haven't used it in 20 years.
Right.
I tend to use triamcinolone, 0.1% ointment, with essentially the same way as Dr. Schwartz uses the betamethasone. And sometimes this is a recurring thing.
Yes, and we, as we said, we used to, if we just saw it adheres 20-something years ago, we would do the estrogen cream. So we don't do that anymore for good reason. If I see it so much to the top, not wetting yet, but like I can hardly tell that anything's coming out, that's the only time I sometimes will treat that. Maybe once a year or once every couple of years.
Yeah, I rarely treat it these days. We were trained to treat it pretty aggressively previously.
Now, pelvic pain with periods or dysmenorrhea can just be a matter of optimizing better pain medication, at least 400 milligrams of ibuprofen, or maybe hormonal management. But if there's persistent pain after 3 to 6 months of medical management, especially if they go on hormones like, birth control pills and they're still in pain, you really want to get a doc experienced with teen endometriosis and consider a laparoscopy. I haven't had one of my patients, but I know my practice have had. This could be missed.
Oh, yeah.
In young women for years.
For sure.
So another pearl that she gave.
Another entity that can sometimes be troublesome is something called urethral prolapse. And so getting back to the little anatomy touch we did a minute ago, so the urethra is at the very top of the vaginal opening. And the urethral prolapse is when there can be profuse and bright red, painless vaginal bleeding, oftentimes associated with a cough or with constipation. So with a time when you're increasing kind of like your intra-abdominal pressure, like a Valsalva maneuver. And the area itself can be a dark red or purple circular mass, kind of a little mound. And it's oftentimes misdiagnosed as a vaginal mass. It's actually the urethra or the tube where the urine comes out kind of, turning itself outward. Treatment for this is our old friend topical estrogen that we no longer use for adhesions, but this is used for urethral prolapse. And then lastly, vulvovaginitis. Again, itis means inflammation. And we see this all the time in young girls. And so once a young lady is outside of the realm of wearing a diaper, this is the most common type of irritation that we see in that area. The key here is hygiene and hygiene and hygiene. And oftentimes, less is best. So we have them do plain water baths or sitz baths. We don't need to put vinegar in there or anything else. It can be associated with inappropriate wiping, and inappropriate doesn't necessarily mean not well enough. Sometimes it means you're wiping too hard, and other times it means that you're not wiping the appropriate places. And then if discharge were to occur, then we have to also be thinking further outside the box, and we will tend to get a vaginal culture, not just a swab, but we need to get, for the best culture, a little bit past the hymen, and we try to do that really quickly so it's not uncomfortable for the child. And you can have them cough first, going with that whole intra-abdominal pressure, kind of forcing things out a little bit type of idea.
Dr. Schwartz's next pearl was always think about vaginal foreign bodies, especially with green, bloody, or smelly discharge. And she always shows this x-ray when she does it. Beware the polypocket vaginal foreign body. And she has an x-ray with, you could see the outline of the polypocket as a vaginal foreign body.
Goodness.
Other big one, we've talked about this before. Little girls do not get vaginal yeast infections.
No.
They don't get. So if you see some inflammation, don't just reach for your nystatin and say, okay, it's a vaginal yeast infection, because they really usually do not get that. She did spend a lot of time talking about abnormal uterine bleeding, increased bleeding, and it's a good review. The normal menstrual cycle is 21 to 45 days, even after the first year of menarche. But even after 2 years, 60 to 80% of young women cycles are between 21 and 34 days. And the mean duration is 5 days, but can range from 2 to 7 days. So even every 3 weeks, 6 or 7 days, that's not out of the realm of normal flow. Anyone whose cycles are over 90 days, even a year after menarche, should be evaluated. But every 3 weeks, again, is normal. The flow is usually less than 80 ml and typically 3 to 6 pads or tampons per day. If you're changing fully soaked products every 1 to 2 hours, that's excessive. There are many causes of abnormal uterine bleeding, including hormonal, eating disorders, PCOS, obesity, thyroid, and hyperprolactinemia. Herbal medicines like ginkgo and ginseng can cause AUB. A pelvic ultrasound is rarely indicated. But always consider coagulopathy. About 20% of women admitted with abnormal uterine bleeding have a coagulopathy, most commonly von Willebrand's disease. So get your CBC, ferritin, iron, coag studies. And if they have irregular menses, add your FSH, LH, estradiol, TSH, prolactin, and possible androgens if hirsute, looking for PCOS, and STD testing if sexually active. And remember, chlamydia can cause spotting. And the treatment is combined hormone methods, hormone patches, vaginal ring, progesterone-only methods. But her favorite way, and I've actually used this, and my colleagues in my office have, to stop significant bleeding is norethindrone acetate, agestin 5 milligrams daily, which is progestin only. It's probably even better than IV estrogen when you're inpatient for severe abnormal uterine bleeding. It's not approved for contraception.
Okay, so moving on to a really important topic, which is oftentimes not something that's considered by most of the folks in the general population. How about GYN care in women, in young women with disabilities? So menses and menarche can be very stressful for many of these patients and for their families as well. NSAIDs can really help to decrease menstrual flow and decrease dysmenorrhea and related mood or behavioral changes. Tranexamic acid, 1,300 milligrams 3 times a day for 5 days, used during periods only, can reduce bleeding. And the things that can be offered to these folks include combining OCPs and other therapies, but never, ever, as everyone knows, can we guarantee zero bleeding. Once again, Dr. Schwartz does like igestin, progestin pill to stop bleeding. This can be used for as long as one desires. There are also hormonal IUDs. These can last for up to 8 years. The brands like Mirena and Lolita, and they can be placed in the operating room. But the initial regular bleeding and cramping may still cause distress for this population. Surgical options like endometrial ablation don't work very well and really are not used anymore. Hysterectomy can stop periods, obviously, but not the hormonal effects of those menstrual cycles. This obviously eliminates the risk of pregnancy, but it doesn't eliminate the potential for abuse, which is always a big concern for this population. And it also has the highest risk of morbidity and mortality, and this really has to be cleared through ethics committees and through legal means if anyone is under 18 years old or unable to provide consent for themselves.
But it's an important thing to mention, right? These severely disabled women who it's very difficult dealing with their periods, and you also don't necessarily want them to get pregnant,
right?
But you also want to respect the agency of the person. So it's a very significant discussion, and we'll do that. But getting someone like Beth Schwartz,
yes,
who does this all the time,
yes,
and trying to honor the family also.
Yes, this deserves a lot of thought and a lot of consideration, and isn't something that one leaps into. Caregivers and the patients are receptive and grateful that you will talk to them about these issues, like having a healthy sex life. Routine GYN care with disabilities is really similar to recommendations for any young woman.
Yeah, and going back to what you said, they really can be appreciative when you ask about their sex life. I had one girl, wheelchair bound for years, and she was an older teenager, and I asked her, "You having sex?" And she just looked at me like no one's ever asked me that before, and really was impactful. So I think it's important that we look, they may have some challenges physically, but we should make sure that if they want to live a whole life, and we should be asking a sexual history. And lastly, I'm going to end up with talking about gynecological compare for gender diverse people. Yes, with all the changes in the world going on lately with care of trans people, trans men and women, we need to take care of them, even if it seems like others are not, even the Children's Hospital, and pressures being put on them. But just briefly to say that puberty and menses can obviously be very distressing for those who don't identify as a female, for a trans man. You can use medications to stop periods, and 90% in her experience, Dr. Schwartz, will use that daily agestin or get an IUD. The guidelines for routine gynecologic care is really the same for trans men. Ovarian and testicular function is suppressed during gender-affirming hormone therapy, and future fertility requires usually stopping those medications. And she ended by saying, don't forget, trans men can get pregnant. So, Maddie, that's all for now, but I'm getting all kinds of messages from all over the place that we stopped too early, so we got to finish a little bit. Oh, that cement is just, it's there for the weight, dear. 5 will get you 10, old Mack, he's back in town. Now to hear about Louis Miller, he disappeared, babe, after drawing out his hard-earned cash. He worked so hard. Now Mack, he spends just like a sailor. Could it be our boy's done something rash? Now Jenny Diver, ooh, sucky tawdry. Ooh, Miss Lottie Linya. I love Lottie Linya.
And Lucy Brown.
Oh, the line forms on the right, babe. Now that Mackie's back in town. Look at old Mack. He is back. And we're at Good Night, Moon.
Good night.
Podcast Pediatricians Productions. All rights reserved.